Hi, my name is Montserrat Palacios and I'm going to present the clinical case report about diverticulitis. This is the case of a 74-year-old woman who has a 10-year history of intermittent lower abdominal pain. The pain has been colicky in nature and is associated with a feeling of distension in the left iliac fossa. It is generally relieved by passive flightus or feces. She tends to be constipated and passes small pieces of feces. 4 years previously, she passed some blood with her bowel motion and had a barium enema performed. Over the last week, her pain has worsened, and now she has continuous pain in the left iliac fossa and feels generally unwell. Her appetite has been poor over this same time. She has not had her bowels opened over the last 2 days. In her previous medical history, she had a hysterectomy for a fibroids 20 years ago. There is a family history of ischemic heart disease and diabetes mellitus. She lives alone and does her own cooking and shopping. At the examination, she has a temperature of 38.5 degrees Celsius and is tendered with a begging pressure of a mass in the left iliac fossa. There is no guarding or rebound tenderness and the bowel sounds are normal. Her pulse is 84 per minute and blood pressure is 154/88 millimeters of mercury. There are no abnormalities to find in the respiratory system. In the laboratories, it is observed hemoglobin 11.8 grams per deciliter, mean corpuscular volume 85, white cell count 50.6 by 10 per liters, platelets 235 per 10 liters, C-reactive protein 56 milligrams per liter. This woman has diverticulitis. Colonic diverticula are small outpouchings which are most commonly found in the left colon. They are very common in the elderly Western population, probably due to a deficit in a dietary fiber. Symptomatic diverticular disease has many of the features of irritable bowel syndrome. Inflammation in a diverticulum is termed diverticulitis. In several cases, perforation, paraalcoholic abscess formation, or septicemia may develop. Other potential complications include bowel obstruction, formation of a fistula into rectum or vagina, and a hemorrhage. The barium enema from 4 years ago showed evidence of diverticular disease with outpouching of the mucosa in the sigmoid colon. This will be consistent with the long-standing history of abdominal pain of colonic type and tendency to constipation. The recent problems with increased pain, tenderness, fever, raised white cell count, and C-reactive and a mass in the left iliac fossa will be compatible with an acute exacerbation of her diverticular disease. In her case, there is no evidence of peritonitis, which would signal a possible perforation of one of the diverticula. The differential diagnosis, with the suggestion of a mass and change in the bowel habit, would be carcinoma of the colon or Crohn's disease. In the absence of evidence of perforation, with leak of bowel contents in the peritoneum or obstruction, treatment should be based on a presumptive diagnosis of diverticulitis. A colonoscopy should be performed at a later date to exclude the possibility of a colonic neoplasm. A CT scan of the abdomen will delineate the mass and suggest whether there is evidence of local abscess formation. Treatment should include broad-spectrum antibiotics, intravenous fluids, and rest. Further investigations are indicated, including electrolytes, urea and creatinine, glucose, liver function tests, and blood cultures. Repeated severe episodes, bleeding or obstruction may necessitate surgery. In conclusion, Diverticulitis is an painful condition that results in a high morbidity and even mortality. Uncomplicated diverticulitis can sometimes be managed on an outpatient basis with a dietary restriction and antibiotics. Complicated diverticulitis and some cases of uncomplicated diverticulitis require hospitalization. Patients need to be placed on a bowel rest and must be given intravenous fluids and antibiotics.